Current presentation will describe Chapter 34, Respiratory Disorders of the Pediatric Population. Please take a few moments and stop the presentation to review the learning objectives for Chapter 36 that covers the respiratory disorders of the children. Respiratory disorders represent a condition that is very common in infants and children, and the severity of the condition may range from mild to very serious and sometimes life-threatening. Those conditions can be both acute or chronic in nature, and sometimes those respiratory disorders may require hospitalization, which will in fact interrupt the normal development of a child-family relationship. In addition to that, the child's patterns of sleep and eat and stimulation will be completely disrupted. When the recovery is rapid and the hospitalization usually is brief, the child will not experience, or they may have only a few long-term effects. However, if this condition is chronic or is so serious that will require long-term care, both the child and the family may suffer from very serious consequences. So we'll start by discussing a little bit about the growth and development of the respiratory system and how this contributes in the etiology or the pathophysiology of the respiratory conditions. So if you remember, the respiratory system is made out of nose and pharynx, larynx continued by trachea. At the level of the larynx, we have the epiglottis. After the trachea, we'll have the bronchi, bronchioles, and we end up with the lung tissue. And at the level of the lung, we have the actual exchange of oxygen and carbon dioxide, followed by the distribution of the oxygen to the body cells through the circulatory system. Now, the alveoli can be affected by a multitude of conditions. Now, the structures and the organs that we found that I just mentioned in the respiratory system, they have a way of cleaning, warming, and humidifying the air that enters the body. So the respiratory problems, as said before, will occur more often and with greater severity in infants and children than in adults. And this is because it may be due to the fact of their immature body defenses, and because their anatomical structures are small and a little bit underdeveloped. While the respiratory tract will grow and will change in a span of about 12 years, however, during the first 5 years, the child's airway will increase in length only and not in diameter. And please remember that because is important. Also, the infants and young children have larger tongues proportioned to their mouth. They have a shorter neck and they have a narrow airway with structures that are closer together. And all those elements will make you think immediately to the possibility of a respiratory obstruction, especially when there will be edema and swelling and an increased mucus production in the airways. If you remember, when we discussed infants, we said that they are obligated nose breathers, and that means that the ability to breathe through the mouth when the nose is blocked is not automatic and develops as the child's neurologic development increases. So remember, I just said that the infant is a nose breather, so if the nasal passage is not cleared, the infant will not going to be able to eat and breathe at the same time. Another aspect is the tonsillar tissue that is or may become enlarged in early school-age child. However, the pharynx, which contains the tonsils, is still very small in diameter. So the possibility of obstruction of the upper airways is very likely. Another anatomical difference is the fact that in children older than 2 years of age, the right bronchus is shorter, wider, and more vertical than the left one. The infants will use their diaphragm and abdominal muscles to breathe. However, around age 2 and 3, the children will start to use their thoracic muscles for breathing. So the change from using abdominal to using thoracic muscles will end and will be completed by age 7. It is easy to understand now how in respiratory failure we'll have accessory muscle used, and the weakness of these accessory muscles will contribute to the respiratory failure. When I was telling you the importance of the fact that the right bronchus is positioned different than the left one, that's important especially when a child is inhaling a foreign body, and there's a higher possibility that that foreign body will lodge inside the right bronchus than the left one. We'll discuss now a few, in the order of severity that they show and they may be in a patient. We'll discuss conditions that are respiratory disorders. We'll start with the acute nasopharyngitis, or the common cold, which is probably the most common infection condition of the childhood. Young infants are especially susceptible more than an older child. However, a young infant is not exposed to the viruses as frequent as an older child. Usually the illness is viral and will be caused by rhinoviruses, Coxsackie viruses, RSV or respiratory syncytial virus, influenza, parainfluenza types of virus, or adenovirus. Bacteria or a bacterial invasion may complicate this type of conditions by accumulating inside the ear, the mastoid, or in the lung, and creating infections in those places. The child is a little bit more susceptible for complication than in adult, and when the complications appears in an infant, it can be more serious than in the adults. In terms of clinical manifestations, we have fever that in a viral condition can be as high as 104, that's about 40 Fahrenheit, that's about 40 degrees Celsius. Very young infants may be afebrile. That means that they may not develop a fever, and that can be dangerous because it doesn't alert us that something is wrong with the child. The child may sneeze, may be irritable and restless, may have congested nasal passage that may interfere with nursing and may increase the irritability, and may present with vomiting or diarrhea. And this is the result of the mucus drainage inside the digestive system that will be the postnasal drainage that the infant will swallow. The diagnosis is made based on the clinical aspects. The first symptoms usually will be those described before. In terms of treatment, for a child that has an uncomplicated cold, nothing more than supportive treatment is needed, as rest, increased fluids, adequate nutrition. When needed, normal saline nose drops to release the nasal congestion, and suction with a bulb syringe in a humidified environment. Acetaminophen or children's ibuprofen may be administered if needed as an antipyretic and analgesic. Aspirin should be avoided because of the concern of developing what is called the Rey syndrome. When the nares or upper lip are irritated, cold cream or Vaseline can be used. The next condition is allergic rhinitis or the hay fever. And in most cases, in children, it's caused by a sensitization to animal dander or house dust or pollens and molds. However, the pollen allergy seldom appears before 4 or 5 years of age. In terms of clinical manifestation, we'll see a watery nasal discharge with what is called a postnasal drip. They will have a lot of secretions getting back in the back of the throat from the nose. Sneezing, conjunctivitis that is allergic, discontinuous sniffing and itching of the nose and the palate will make them to have what is called the allergic salute. The child is pushing his or her nose upward and backward to relieve itching and opening the air passage of the nose. Because of the congestion at the level of the nose, there is some kind of backup pressure that builds up to blood circulation around the eyes, and in some children, they will have dark circles visible under the eyes. In some cases, children are complaining also of headaches. As a treatment, most important is to, and when possible, of course, is to avoid the offending allergens and remove them from the child environment. Antihistaminic treatments such as pseudoephedrine and decongestants can be helpful in some patients. We can perform what is called a hyposensitization, especially in those cases that antihistaminics are not helpful or are needed for as a chronic measure. We'll need also to educate the family about the importance of avoiding allergens. Tonsillitis and adenoiditis. Tonsillitis, itis, infection, inflammation / tonsillitis is common illness in childhood resulting from pharyngitis. It's kind of a progression of the infection of the pharynx into the tonsils. Now, let's review a little bit the location and functions of the tonsils in order to understand a little bit better also the pathophysiology and the treatments. So the tonsils are part of a ring of lymphoid tissue that encircles the pharynx, and the main role of this ring is to form a protective barrier against upper respiratory infections. So we have a group of lymphoid tonsils that are located in the pharynx, and those are called adenoids. We have the lingual tonsils, and we have the fascial tonsils, those that are in the pharynx. Normally, the lymphoid tissue will start to enlarge progressively in childhood, somewhere between the ages of 2 and 10 years of age, when the tissue is hyperstimulated and the child comes in contact with more and more antigens, and will shrink during pre-adolescence. If the tissue itself becomes a site of acute or chronic or acute on chronic infections, the tissue may become hypertrophied, may enlarge, and may interfere with breathing, causing partial deafness, because if you remember, the fascial one, they are close to the opening of the eustachian tubes that communicate between the pharynx, is the communication between the middle ear and the in the pharynx. And they become also a source of infection through that port. As clinical manifestation, we'll see a fever that is around 101, that's about 38.4 Celsius. It can be even higher in some cases. Sore throat, often with what is called dysphagia, or difficulty to swallow. Hypertrophied tonsils, and erythema of the soft palate. When examining the patient, we may see an exudate visible on their tonsils. And the symptoms may vary based on what is the organism that is causing the problem. In terms of diagnostics, we need to perform a throat culture. And in most of the cases of tonsillitis, the result will be a beta hemolytic strep infection or a viral infection. In terms of treatment, the medical treatment consists of offering analgesics for the pain, antipyretics for the fever, and an antibiotic in case of the streptococcal infection. We'll educate the patients about soft or liquid diet that will be easier for the child to swallow, especially in the acute phase of the condition, and to encourage the child to maintain good fluid intake. We can use in the environment a cool mist vaporizer that will ease the respiration. Please make sure that you emphasize for the patients the importance of the 10-day course of antibiotics in order to have a correct treatment of tonsillitis. This treatment needs to be completed and not stop in the middle or stop when the moment that the child does not have fever or feels better. In terms of surgical treatments, tonsillectomies and adenoidectomies can be controversial. Those can be performed together or individual, independent of each other. Well, there was no conclusive evidence that shows that tonsillectomy in itself may improve the child's health by reducing the number of respiratory infections. However, they may improve the general well-being. So currently, tonsillectomies are generally performed only when other measures have proven ineffective and the tonsils are so hypertrophic that breathing and eating are difficult. The procedure is not performed when the tonsils are infected, not in the acute stage of the condition. As a general rule, the adenoids are a little bit more susceptible to chronic infection. So in addition to adenoidectomy, as an indication for adenoidectomy, it will be the hypertrophy of the tissue that, as an extent of it, may impair the hearing or may interfere with breathing. We have those cases of children that will have sleep apnea, and they will have an effective type of growth and development due to a periodic hypoxia, especially during the night. Regarding nursing intervention, especially for the postoperative period, the most important part immediately after the procedure is to prevent postoperative aspiration. The child needs to be partially prone with the head turned to the side until the child is completely awake. And because this type of procedure is involving an artery that is not extremely big, however, it may bleed badly, we may need to avoid to discourage the child from coughing because that may dislodge the blood clot from the place of the surgery. We need to check vitals every 10 to 15 minutes until the child is fully awake, and every 30 minutes to 1 hour after that. Will provide comfort and relieve pain. We may do that by applying an ice collar and definitely remove it if the child is not happy with that or uncomfortable. In terms of pain medication, that can be administered IV or rectal. Crying usually will irritate the raw throat and will increase the child's discomfort, so we try to avoid that as much as possible. We'll encourage fluid intake, and immediately as the child is fully awake from surgery, we'll give small amounts of clear fluids or ice chips. Synthetic juices, carbonated beverages that are flat, and frozen juice popsicles are also good choices. We'll, however, avoid any type of irritating liquids as orange juice or lemonade. They are acidic. Also, we'll avoid milk and ice cream products because they tend to cling to the surgical site and make swallowing more difficult. So your previous old misconception that ice cream is offered after tonsillectomy is not true. Also, after tonsillectomy, we'll try to offer liquids that are not red in color to eliminate any confusion with any type of bloody discharge or bleeding. We'll observe the child, especially in the first 24 hours and after surgery, and around day 5-7, we educate the parents regarding the moment when the blood clots may dislodge, and sometimes some bleeding may show up. Any type of unusual restlessness, anxiety, frequent swallowing, or rapid pulse need to be reported immediately. And of course, whenever there is a vomiting of bright red blood, that needs to be reported to the provider. Question number 3. What is one of the major nursing interventions with a child who has had a tonsillectomy? A. Family teaching. B. Preventing preoperative aspiration. C. Preventive excessive fluid intake. Or D. Family interactions. The answer is family teaching. And usually the child is typically discharged on the day of or sometimes the day after the surgery if no complications are present. we need to instruct the caregivers, the family, to keep the child relatively quiet for a few days. We recommend soft foods and non-irritating liquids for the first few days, and we'll teach about how to note and how to react if there are any signs of hemorrhage, as bright red bleeding, frequent swallowing, or restlessness. We will discuss now a different group of respiratory disorders, and it's called the croup syndromes. And croup per se is not a disease, but a group of disorders that will have in common a barking cough, hoarseness, and respiratory stridor. And the stridor is that kind of really harsh respiratory sound that the child is making while breathing. And the name of different types of disorders is given by the name of the structure that is involved. And you'll see in a second when we start to discuss those. First of them is called spasmodic laryngitis. And laryngitis will involve, obviously, the larynx. And occurs in children between ages 1 and 3. And there is no real cause to be identified for this condition. It can be infectious or allergic in origin. However, the children will show the signs of a severe laryngospasm without having a real cause for that. In terms of clinical manifestation, everything started with a runny nose with coryza and the hoarseness, and with no obvious signs of respiratory distress during the evening. The child will go to sleep and awakes after a few hours of sleep with a bark-like cough, increasing respiratory difficulty and stridor. The child is anxious and restless and markedly hoarse, and all those are signs of typical for respiratory distress and also for hypoxia. They may or may not have a little bit of fever, low-grade fever, and mild upper respiratory infection may be identified. This condition is not serious, however, it will frighten both the child and the family. Usually the episode subsides after a few hours, and in the morning there is no evidence of what happened during the night. Usually those attacks will happen for a couple of nights, 2-3 nights, and they will completely disappear. And there's a treatment. What we can do is to provide humidified air that will, we'll prefer to do what is called a cool mist humidifier and not a vaporizer, because that can burn the child. Make sure that you educate the patients in terms of cleaning humidifiers and vaporizer to prevent the growth of microorganisms inside. Sometimes this spasm can be relieved by exposure of the child to cold air. For instance, if we are taking the child out outside in the night while going to the emergency room, that can chill and calm the child, and by the arrival to the emergency room, they have no signs or symptoms. Now, it is important to explain to the parents that all those symptoms can be treated at home, and that's not a serious condition. Also, they may need to understand that this condition may reoccur, and it may happen again later. Acute laryngotracheal bronchitis is common in small children, and this condition will involve tracheobronchial areas. The acute one, that can be bacterial, may progress rapidly and may become a serious problem in a matter of hours. Most of the times, the age group affected is the toddlers. The condition can be viral and sometimes may be associated with bacterial invasion, usually staphylococcal. It's generally following a fairly mild rhinitis and pharyngitis. And in clinical manifestations, the child will develop a hoarseness and the barking cough with fever that can reach very high levels, 104, 105, that's 40.5 Celsius. As the disease will progress, there will be an increased laryngeal edema, and the child's breathing will become more and more difficult. And the pulse will become more and more rapid, and sometimes may develop cyanosis. As a treatment, the major goal will be to maintain the airway and to provide adequate air exchange. We can also provide antimicrobial therapy if ordered. However, the child will be placed in a supersaturated atmosphere, and that's what it is a crew pet or some other kind of mist tent where we can administer oxygen. We'll need to provide a treatment that will achieve bronchodilation, and that can be done by nebulizing epinephrine. The nebulization therapy will be administered sometimes every 3 to 4 hours and will produce rapid relief because it causes a vasoconstriction and relief of the edema. The child will require careful observation and, if necessary, intubation using a nasotracheal tube may be performed. Epiglottitis. It's an acute inflammation of the epiglottis. The epiglottis is that cartilaginous flap that protects the opening of the larynx. It's usually most commonly caused by the Haemophilus influenza type B. The age group is 2 to 7-year-olds. The epiglottis will become inflamed and swollen with edema that will decrease the ability of epiglottis to freely move, and that will result in a type of blockage of the airway and will create an emergency. In terms of clinical manifestation, usually the child may have been very well or may have had a mild upper respiratory infection before developing a sore throat. That is followed by dysphagia and the high fever that usually will be up to 104, not more than that. What's typical for this condition is the drooling, that it looks like the child is not able to swallow its own saliva. The child may look anxious and will prefer to breathe by sitting up and leaning forward with the mouth and the tongue out, mouth open and the tongue out. And this is called a tripod position, and it's very typical for all the children that experience this type of phenomenon. And this may signal that this is an emergency situation. In terms of treatment, in some cases may need an endotracheal intubation or a tracheostomy if the moment of an endotracheal intubation was lost and the intubation cannot be performed. Moist air will reduce the inflammation. We'll need to monitor through pulse oximetry, and antibiotics may be administered IV. Usually 24 to 48 hours of therapy, the child will do better and can be extubated, and however, the antibiotic therapy needs to be continued for up to 10 days. Acute bronchiolitis, or the respiratory syncytial virus infection. Well, the acute bronchiolitis or the acute interstitial pneumonia, this is very common during the first 6 months of life, and pretty much is rarely seen after the age of 2. So most of the cases will occur in infants who have been in contact with older children or with adults that had an upper respiratory viral infection. It is very typical for winter and early spring. It's a viral infection with, as I said before, up to 50% of the cases being the result of an infection with RSV. Other viruses associated with the disease are parainfluenza or adenovirus. In this type of condition, the bronchs and the bronchioles will be plugged with a thick mucus that will cause air to be trapped in the lungs. The child can breathe air, but it has difficulty expelling it. So the gas exchange at the level of the alveoli is compromised and cyanosis may appear. Usually in clinical manifestation, the dyspnea or difficulty of breathing is shown as very abrupt, and sometimes is preceded by a cough or some type of nasal discharge. It may be a dry or persistent cough with extremely shallow type of respiration. The child seems air hunger and may have cyanosis. We may observe for suprasternal and subcostal retraction as a sign of labored breathing. The chest will become barrel-shaped from the trapped air, and the respiratory rate may increase to 80 breaths per minute. Fever will not going to be extreme, will be in the range of 101, 102, that's 38 up to 39 degrees Celsius. However, dehydration may become a serious factor, and the infant will appear obviously apprehensive and restless and irritable. The diagnostics, in terms of diagnosis, we do that by confirming a lab test, which is an ELISA test of the mucus, confirming the agent that is causing the condition. However, the diagnosis is made by examining the child and performing X-rays. In terms of treatment, the child is usually hospitalized and will be treated with high humidity in a mist tent, rest and increased fluids. We may also provide oxygen by nasal cannula or in some cases by an oxy hood. That's a hood that is placed over the infant's head. We'll monitor for the levels of oxygenation. Antibiotics are not prescribed because this is a viral condition. All we need to do is to offer good fluid intake and to permit the infant to rest. There is an antiviral drug that is called Virazole or ribavirin that is used in some in special cases to treat the RSV. It is administered as an inhalant by a hood, mask, or tent. So, however, the American Academy of Pediatrics recommends the use of ribavirin to be limited only for those with high risk for severe complications, such as children that already have a chronic lung disease in premature infants, in transplant recipients, or those that are receiving chemotherapy. Keep in mind that ribavirin is a high risk for teratogenity. It can cause damage to a fetus, so the healthcare personnel that may inhale the mist that escapes into the room must be advised about this this warning. Asthma represents a condition in which there is a spasm of the bronchial tubes caused by the hypersensitivity of the airways. In the spasm is followed or comes together with an inflammation that leads to mucosal edema and mucus hypersecretion. In some books, in some literature, is called also the reactive airway disease. It is a reversible type of obstructive airway disease and is extremely common in the United States, with up to 8.5% of all children being affected by that. So asthma attacks can be triggered by a hypersensitivity response to allergens. It may be triggered by foods, by exercise, by exposure to cold weather, by irritants as wood-burning stoves or cigarette smoke or dust or pet dander. And in sometimes the foods that I was mentioning before can be chocolate or milk, eggs, nuts, or grains. Some infections, such as bronchitis, may trigger and provoke an asthma attack. And in some of the children with this condition, emotional stress and anxiety may start to track too. The asthma can be intermittent with extended periods that the child has no symptoms whatsoever and does not need any type of medication, or it can be what is called chronic and will need frequent or continuous therapy to prevent attacks. Because it's a chronic condition, it may affect the child's school attendance and academic performance and may impair their general activities, contributing sometimes in some children to poor self-confidence and dependency. In terms of the clinical manifestation, the onset of the attack can be very abrupt and can progress over it can be very abrupt or can happen through several days. When it progresses through several days, they have this kind of dry hacking cough followed by wheezing, and the wheezing is the sound of expired air being pushed through obstructed bronchioles, and they seem to have a difficulty breathing. They are more often at night and will awake the child from sleep. When up, the child must sit up and is very preoccupied by the efforts of breathing. Those attacks may last for a very short time or may continue for several days. Many children will overgrow that and will, by puberty, will be free of symptoms. In other cases, other allergies may develop throughout their life and after that, even in the adulthood. In terms of diagnosis, the history and the physical examination are very important for the diagnosis. We observe the child type of breathing, uh, the dyspnea and the labor breathing, and um, very typical for asthma will be to hear the wheezing and will oscillate the child's lung sounds. The mucus production can be profound in some cases, and that will mandate to perform some pulmonary function tests to evaluate the amount of obstruction. In terms of treatment, um, we need to teach the family and the child in how to recognize the symptoms that may lead to an acute attack so they can treat it as soon as possible. Um, we will train them and educate them on how to look uh, for the respiratory retraction, wheezing, an increased amount of coughing at night or in the early morning or whenever the child is increasing the physical activity. We can use a peak flow meter to as an objective way to measure airway obstruction. Um, and in the case of a family that is using a peak flow meter, they will keep a diary, a peak flow diary, where they will include the symptoms whenever they have exacerbation, action taking, and outcomes. Also, the family must make all the efforts to eliminate any possible allergens from the house. So the main goal of asthma treatment will be actually to uh, prevent the symptoms, prevent an attack, and maintain as much as possible a normal lung function and activity level, preventing any type of exacerbation that may be followed by hospitalization. Um, that may be done with treatment in the cases that they need treatment. And for those that are taking medication, we'll look for um, um, having as few adverse effects as possible. In terms of medication used for treatment of asthma, we have two categories. We have the quick relief medication that will be used for immediate treatment of symptoms or exacerbations, and we have the long term that controls the symptoms and maintain an open and free airway. So we have bronchodilators that can be sympathomimetics or xanthine derivatives, and we have anti-asthmatic drugs like corticosteroids, leukotrienes inhibitors, and mast cell stabilizers. Many of those medications will be given by nebulizer, which is a tube attached to a wall unit or cylinder that will deliver moist air uh, through a facial mask, or they can be delivered through a metered dose inhaler, MDA, which is a handheld plastic device that delivers a pre-measured dose. Usually the MDA may have a spacer unit attached that makes it easier, especially for the young child to use. The bronchodilators can be used for quick relief of an exacerbation. They are short-acting. They are available in the form of a pill or liquid or inhaled form. Those drugs are usually administered every 6 to 8 hours. Um, if there is a pill, or every 4 to 6 hours for inhalations, if and when the breathing is difficult. In severe attacks, epinephrine can be administered in subcutaneous injections for a quick relief of the symptoms. In some cases, some bronchodilators, such as salmeterol or Servent, are used also for the long-term control. Theophylline preparation have been used for a very long time in the treatment of asthma, and the drug is available in short-acting and long-acting forms, with the short-acting being good for being administered every 6 hours, while the long one being administered every 8 to 12 hours. Corticosteroids are anti-inflammatory drugs that will control severe or chronic cases, may be also given in inhaled form to decrease the systemic effect that usually will be followed, will usually follow an oral steroid administration. Leukotriene inhibitors are given by mouth, and they are used for long-term control and prevention of persistent asthma. Mast cell stabilizer will stabilize, obviously, the cell membrane of the mast cells, and by doing that, preventing the release of the chemical mediators that will cause the bronchospasm and the mucous membrane inflammation. And by doing that, they will help decreasing the wheezing, and they are also very good in exercise-induced asthma attacks. They are non-steroidal anti-inflammatory drugs and have, because of that, relatively few side effects. We can also offer just physiotherapy. So during those sessions, the family and the child will be educated in breathing exercises that will improve the respiratory function and will control the asthma attacks. Bacterial pneumonia, and in this category, we'll talk about the pneumococcal pneumonia, which is the most common form of bacterial pneumonia in infants and children. The disease occurs mainly in the late winter and early spring, and it can be seen in children younger than 4 years of age. Again, pneumococcal pneumonia, it's a bronchial type of pneumonia. In older children, it's generally a lobar type, while in infants will be bronchial. It is usually secondary to an upper respiratory viral infection. When we are looking at an X-ray, we'll see in an infant a patchy infiltration of one or several lobes of the lung. Sometimes a pleural effusion may be present. In an older child, the pneumonia may be lobar. It means it's localized to the whole lobe. Another type of pneumonia is caused by the Haemophilus influenzae in infants and young children, with clinical manifestation very similar to the pneumococcal pneumonia. However, the clinical course can be longer and less acute, and the complications in the infant are common, usually through bacteremia. They may develop inflammations of the pericardium and emphysema, pus at the level of the lungs. In terms of clinical manifestations, the onset of the process is usually abrupt, following a mild upper respiratory infection with temperature that will increase very high, up to 105, that's 40.6 Celsius, with an increased and marked respiratory distress. There will be an obvious air hunger with flaring of the nostrils. The infant will show circumoral around the mouth cyanosis and chest retractions. In addition to that, the child will show tachycardia and tachypnea with up to 80 breaths per minute. The cough may not be noticeable at the onset and may show up a little bit later. The diagnosis is based on the clinical symptoms, the chest X-ray, and the culture of the microorganism in the secretions. Usually on the lab test, the white blood cell count will be elevated. The treatment is to provide antibiotic therapy with penicillin or ampicillin. They're both very effective, and they can be used unless the child has a penicillin allergy. Cephalosporin can be also used. Oxygen needs to be started early in the process. In some instances, the infant should be placed in a mist tent or a croup-pet. Cystic fibrosis was at the beginning, when was described, was called the fibrocystic disease of the pancreas. And later, when more research was done, it was observed that the condition affects not only the pancreas, but also the lungs and the liver. And because half of all children with cystic fibrosis have pulmonary complication, now it's been seen way more as a respiratory condition than it was in the past. Cystic fibrosis is a hereditary autosomal recessive trait. So in other words, both parents must be carriers of the gene for the cystic fibrosis to appear. With each pregnancy, the family has a chance of 1 in 4 chance that the child will have the disease. Overall, in the United States, there is an incidence of 1 in 3,000 in white children and 1 in 1,500 in African American children. The main issue with the cystic fibrosis is an abnormal gene that in a normal individual produces a protein that is a conductance regulator. In other words, serves as a channel through which the chloride ion enters and leaves the cells. In a mutated gene, that regulator is not created, and as a result, there is in return there is an abnormal secretion of the sodium as a result of impaired transportation of chloride. By blocking the chloride transport and increasing the sodium transport will increase the abnormal secretion of exocrine glands that will become thick and mucus-like instead of being thin and free-flowing type of secretion. And this is seen at the level of the pancreas and at the level of other glands. However, it's obvious at the level of the lungs where the thick mucus will obstruct the respiratory airways and will cause trapped air and overinflation of the lungs. In terms of clinical manifestation, what we'll see in our patients will be the fact from the birth. They will show what is called the meconium ileus in up to 1 in 5 out of the newborns. And this is the result of the depletion or absence of pancreatic enzymes before birth that will result in an impaired digestive activity with a meconium that is very thick and sticky. In addition to that, the newborn will have a salty taste when kissed because of the elimination of high sodium chloride. It's a high elimination of sodium chloride in their sweat. Initial symptoms of cystic fibrosis may start at any age. They can start in infancy or in the childhood and sometimes in adolescence. And that will be a hard, non-productive chronic cough as the first sign. Later will be frequent bronchial infections. And as a result of that, the child will develop a barrel chest and clubbing of fingers as a chronic hypoxia. The abdomen may become distended and body muscles become flabby. At the level of the pancreas, there will be a very thick mucus that will obstruct the pancreatic ducts. So there will be a malabsorption of fats because of decreased pancreatic enzymes production. At the level of the lungs, and pretty much the degree of the involvement of the lungs will determine the prognosis for survival. The more severe the pulmonary involvement, the more critical the prognosis will be. Nowadays, with the type of treatments that we have, more than half of the children that have cystic fibrosis will live beyond age 18. The biggest danger in the case of the child with cystic fibrosis will be a respiratory complication. Because of the abnormal amount of thick mucus that will clog the respiratory airways, that will create an ideal medium for bacterial overgrowth, and as a result of that, they have subsequent and numerous respiratory infections. And as a result of that, they may develop atelectasis and small lung abscesses, bronchiectasis, and emphysema at a certain point. As a result of lungs being affected, down the stream, the heart may be affected later in life, developing right ventricular hypertrophy or cor pulmonale that can be a common cause of death. There will be other organs also involved. As said, other glands are also influenced by that. In hot weather, the loss of sodium chloride and fluids through sweating can be so important that may cause what is called heat prostration. So additional fluid and salt should be given in the diet as a preventive measure. This is one of the conditions that it's very important to supplement salt in the patient diet. Males with cystic fibrosis who reach the adulthood most likely will be sterile because of the blockage or absence of the vas deferens and other ducts. In females, the thick cervical secretions may prohibit the passage of sperm. The diagnosis is based on the family history, on examination of sweat that will show elevated sodium chloride levels, by analyzing duodenal secretions that will show lack of trypsin. In children, we'll see a history of failure to thrive, a chronic or recurrent respiratory infection, and the X-rays will show signs of hyperinflation and bronchial wall thickening. The principal diagnostic test for confirming cystic fibrosis will be the sweat chloride test using the pilocarpine method. This method will induce sweating by using a small electric current that carries topically applied pilocarpine into a localized area of the skin, and elevations of 60 milliequivalent per liter or more are diagnostic. In terms of the treatment, depending on the age of the child. So in the newborn, meconium ileus need to be treated with hyperosmolar enemas very gently to remove the blockage of this thick, sticky meconium that can cause an intestinal obstruction. In the older child, the treatment will look into correcting the pancreatic deficiency and to improve the pulmonary function, and also preventing respiratory infection. The overall treatment goals are to improve the child's quality of life and to provide as long survival as possible. From a dietary point of view, there are commercially prepared pancreatic enzymes that can be given during meals. And because the pancreatic enzymes are inactivated in the acidic environment of the stomach, there are some microencapsulated capsules that are used to deliver the enzymes where they need to function, and that is in the duodenum. The child's diet needs to have to be high in carbohydrates and protein with no restriction of fats. And usually during their growth period, they may need 1.5 to 2 times the normal caloric intake. Usually those children may have large appetites unless they are acutely ill. Because of the increased loss of sodium chloride, they also should be allowed to use as much salt as they wish, even if from an outside point of view it may think it's too much. Especially during hot weather, additional salt should be provided. They need to be supplemented with fat-soluble vitamins as A, D, and E that are necessary because they're poor digestion of fats. Also, vitamin K need to be supplemented if they have or show any type of coagulation problems, or if they have scheduled any type of surgery. The pulmonary treatment will have as a main goal preventing and treating respiratory infection. The respiratory drainage will be provided by thinning the secretions and through mechanical means, which is the postural drainage and clapping that will allow to loosen and drain secretions from the lung. When needed, antibacterial drugs will be provided. Now, physical activity is essential because it improves the mucus secretion and helps the child feel good, and also helps the child to develop normally. So the child should be encouraged to participate in any aerobic activity he or she will enjoy. And the activity and the physical therapy should be limited only by the child's endurance. We can also use inhalation therapy that can be both preventive or therapeutic. We can use bronchodilators as theophylline, um, and also we can use mucolytic that is as mucomist or acetylcysteine, especially during acute infections. Question number 5. Tell whether the following statement is true or false. In the newborn, meconium ileus is the earliest sign symptom of cystic fibrosis. Meconium ileus is treated with gently administered hyperosmolar enemas. The answer is true, and the rationale is in the newborn, meconium ileus is treated with hyperosmolar enemas that are administered gently to release the very thick, sticky meconium. And meconium, due to the metabolic disorder, it's sticky and is the first sign or symptom that can be seen in most of those cases. Tuberculosis is a condition that can be found everywhere in the world and represents one of the most concerning chronic infections. Um, and this because of its increased rates of death and cost associated with illness. The incidence in the United States has declined steadily. However, in the last 10 years, we can see an increase in incidence due to immigration. Several factors will also contribute to that. Is the increasing in number of people that have the human immunodeficiency virus, the HIV, and they are actually contracting also the TB. The TB is caused by Mycobacterium tuberculosis, which is a bacillus that spread by droplets of infected mucus. So it's an airborne type of disease that is spread out when an infected person sneezes, coughs, or laughs. Once inhaled, the bacilli will populate and will implant in the lung tissue of the new host. As a result of that, they form what is called a primary lesion. In terms of clinical manifestations, the condition has various stages. It starts with a primary lesion, and most of the time the primary lesion may be unrecognized. The most common site will be the alveoli. And in most cases, the primary lesion will arrest, will not develop more than that, and will heal with a calcification. In some cases, the patient, in the case of our presentation today, the children with poor nutrition and health, the primary infection may invade other tissues, including bone, joints, kidneys, and even meninges. And this is called miliary tuberculosis. In a small number of children, this miliary tuberculosis will have general symptoms of a chronic infection with fatigue and lost weight and low-grade fever. And typical for the TB will be accompanied by night sweats. We also have a different type of tuberculosis that is called a secondary tuberculosis, and this is a reactivation of a primary healed lesion and may occur in adults. And as a result of a secondary tuberculosis, that will expose later children to the microorganisms. And the symptoms of a secondary one, they are very much the same as the one in the first case of the miliary tuberculosis. In terms of diagnosis, we can perform a tuberculin skin test as the primary means by using a multipuncture device. About 0.1 milliliter of purified protein derivative is injected, and as a result of that, there will be a immune response from the patient side. And the site is marked in red at 48 and 72 hours. What we are measuring is the redness, swelling, and induration that will indicate a positive reaction. Now, any type of positive reaction will be further examined by radiographic evaluation. We also can analyze sputum test and perform cultures. The treatment will be by administering isoniazid, often in combination with rifampin. Now, they both have a lot of side effects, and they may cause peripheral neuritis in children with poor nutrition. However, rifampin is tolerated well. May cause body fluids such as urine, sweat, tears, and feces to turn orange-red. Also, it may permanently stain contact lenses, so we need to advise the patients in advance about that. The drug therapy needs to be continued 9 to 18 months, and after drug therapy has begun, the child or the adolescent may return to school and normal activities unless clinical symptoms are evident. Following the therapy, an annual chest x-ray is necessary from that time on. In terms of prevention, prevention will require improvements in social conditions, preventing overcrowding, poverty, and poor healthcare. A vaccine called Bacillus calmette-guerin, or BCG, is used in countries with high incidence of tuberculosis. It is given usually to tuberculosis negative person, and it's considered to be effective for 12 years or longer. After the administration of a BCG vaccination, the skin test will always be positive. So keep in mind that the screening is no longer an effective tool. And the use of this vaccination remains controversial because of the effect that it has on the screening, as well as some people are questioning even the effectiveness of this vaccine.